Hi there, this is Johanna Ralston, and I'm CEO of the World Obesity Federation. So thank you so much to people for joining this webinar today. We'll get started now, and we have a number of really interesting speakers, so we look forward to hearing from all of them. As you know, this is a webinar on universal health coverage and obesity. This is in advance of the U.S. General Assembly high-level meeting on universal health coverage on the 23rd of September in New York at the UN headquarters, with a number of heads of state attending. One practical issue is if you are on the call, please do mute yourselves and use the chat function for questions. That way we can manage having people calling in from so many parts of the world. That goes for speakers as well as people who have joined the call. So today for this call, we'll learn a bit more about what is universal health coverage? What does that mean? What is our definition? Why is it important? And what's its relevance to obesity? You'll hear on updates on research on obesity and health systems. We'll hear from members and patients about dealing with obesity in the healthcare system at the country level. And then we'll speak a bit more about the work that we're doing moving forward around universal health coverage. And want to hear, again, some of the work that you all are doing in terms of working to make sure that obesity is addressed in health systems. So again, as I mentioned, I'm Johanna Ralston. This is our members webinar. We're really, really pleased that you're all here. And it's now my great pleasure to introduce our next speaker, Rachel Thompson, who is our policy fellow here at World Obesity Federation.
Thank you, Johanna. Next slide, please. So I'm going to talk about this concept of universal health coverage, which some of you may have heard of, some of you perhaps not, which is also completely fine. This is the purpose of this webinar. It's very much an introduction, because we realize that for people working in obesity, it may not be something that you have come across directly in your work, but it is something that we believe is relevant, and that's what we'd like to talk about today. So here is, up on the first slide, a simple definition of universal health coverage, which is also known as UHC, I should add, if you hear that abbreviation. All people receive the quality health services they need without suffering financial hardship. So here it's a universal aim, coming from some of the United Nations human rights declarations, also in the Sustainable Development Goals, that all people, whether you are rich, whether you are poor, whichever country you're in, whatever your health condition, you receive the services you need, but also crucially, ideally you should not pay for them, and you should not pay for them any more than you can afford. Thank you. So here is spelling that out a little bit further. Universal means everybody. It means nobody's left behind. Universal health coverage is about equity. And by this, we mean that health services are allocated according to need, and that the people with more need get more services, very simply. There's also a concept whereby the healthy and wealthy will support financially through taxes, for example, the sick and the poor. And this is really, this idea of equity that World Obesity is supporting through universal health coverage. We also have in universal health coverage a focus on quality. It's all very well having every service under the sun, but what if you do not have the correctly trained healthcare workers, equipment, resources, infrastructure? We need to have all these things in place, all these health systems components in place in order to achieve universal health coverage for everyone. Next slide. Here is a very technical slide, and I apologize for it looking a bit daunting. It's what the health economists, especially involved in universal health coverage, are using. And it shows the three key components there as financial, economics, health, and also politics, crucially. So what we want to do is we want to fill up this cube. This is the goal of universal health coverage advocates, global health advocates. When we fill up the cube, it means that more people, the population there on the bottom dimension, will be covered with more services, which we have there in the health dimension, but also people will not be paying. So here we have this phrase, out of pocket. So we do not want people to be paying out of pocket for services, because this means that we reduce the chance of achieving equity. Because if you are poor, or for whatever reason you cannot afford the services we know for obesity are often very, very expensive, you will not be able to achieve the level of health and well-being that you should have. Thank you. A note on politics. So this is the Director General of the World Health Organization, Dr. Tedros, and he has really been the champion of UHC since he began his time in office. He is a former politician, and he knows all too well how important political commitment is for achieving health goals, and especially heads of state. So yes, we want to advocate to ministries of health, we want to work with them, but we also need to advocate to ministries of finance to get the resources and investment in health, especially some of the more currently exclusive services that obesity will often find itself in. Obesity services will often find itself in. So for him and for many others, it is a political project. So as much as anything, we need to be political, and we need to advocate for health to heads of state as well as to ministries of health. As Johanna mentioned, very soon, later in this month, there'll be a high-level meeting at the United Nations General Assembly. So Johanna will be there representing World Obesity. Myself and Claudia will also be at the UN. And this is a really good opportunity to make our voices heard. Every health community will be there, and we are the only voices of obesity. And that's why I'll talk about it at the end, the opportunities that we have on social media to get our messages out there that obesity is a disease and that it needs to be included in universal health coverage. And what do I mean by this? I mean that when governments are deciding which services they should pay for and that they should fund, allocate resources to, allocate health workers to, we need obesity to be there first and foremost. But it will not happen automatically. We need to do a lot of advocacy, and that's why we really need our members' help. So just in case this is what some of you are thinking, very interesting political project, universal health coverage, what does it mean for obesity? So back to the cube, really, yeah, what it means is that more of the population, can I have the next slide? More of the population is covered by more services that will prevent and treat obesity, but fewer of these people are paying out of pocket and are, for example, getting into debt by having to take out a loan to cover maybe the surgery that they need, which we see all too often. And if we have these things in place, we will get equitable access to health services. And this is a nice graphic that we've prepared and will be available for you to use in your social media too. Another graphic here showing the different components that will go into universal health coverage in the big picture. So I've mentioned already health workers. Community, community empowerment, also very important, and that's where we have a role as civil society and as patients and advocates. We also, of course, need more data, better data. We need to monitor. We need to count, and we need to count how many people are living with obesity so we can do something about it. But we know that that is not happening in every country and not as regularly and as well as it should be. Increasing public financing for health is also key, and that's what I've talked about a bit earlier. We need to advocate to ministries of finance as well as to ministries of health to invest in health and to invest in obesity services. We also need strong accountability mechanisms to make sure that the things we are asking for get done. How do we pay for it is a slide that I've left a little bit in draft form for now, because it does get quite technical and quite into health economics, quite complex health economics, which is maybe not the focus of this webinar, but it's important just to know that we need to back up our advocacy calls for more services and for more investment with solutions for how. And that's actually where we have some great solutions in the form of fiscal measures, like, for example, a sugar tax, which can increase money for the government at the same time as preventing obesity. But now the focus for now of the webinar will be on the health system's perspective, which is, of course, at the heart of universal health coverage is the health system. And this is actually something where many of us will be a place where many of us will be working and familiar with, and where some of our messages can have a really strong impact. So I'm going to pass over to my colleague Junaid to talk about this. So thank you very much.
Thank you, Rachel, for that introduction into UHC and the global agenda. So my name's Junaid Powis, and I'm the Health Systems Coordinator here at World Obesity. And what I'm going to talk about very briefly is what all this means for obesity and health systems more broadly, before we hear from some individual countries. I think the easiest way to think about what UHC means for obesity and health systems is to look at the three components that Rachel talked about. So that's equity, quality of care, and financial protection. With these components in mind, it becomes clear that what we need to consider includes some of the following. So for equity, we need to have a health system that is accessible to all, with particular considerations for those in rural areas. What this means in practice differs depending on the health system setup in each country. As an example, in a social insurance type system, we need to consider whether the unemployed are covered for treatment. In an NHS type system, we need to consider whether coverage extends to undocumented migrants. And in a private insurance type system, we need to consider what happens to the uninsured. For the quality component of UHC, there need to be not only up-to-date guidelines, but also the resources in place to ensure that they are followed and implemented. And finally, for financial protection, this is probably the component we hear about the most in terms of obesity, because we know that obesity care in many countries is sought privately at high cost to the individual. So what we need here is for obesity care to be covered by government or social insurance provision where possible to protect the individual. So I hope that many of you are aware of our ongoing health system project, where we are gathering in-country intelligence on health system practices for obesity policy, prevention, and treatment. To date, we have interviewed or surveyed over 280 people from over 65 countries, and we have report cards for 30, which we are updating currently with the view to add at least 20 more. And the aim of this project is to better understand how well health systems are currently working for obesity, and to understand what needs to be done to improve the situation, both within and across countries. So with UHC in mind, I'm just going to go through some provisional findings that we found back in April. The extent to which health systems classify obesity as a disease is often an indicator to how well obesity is provided for within systems, and how many resources are dedicated to it. And so what we can see here is that very few healthcare systems are currently classifying obesity as a disease. This is particularly the case in lower middle and low income countries, but even in high income countries, you can see there's much work to be done. And so it is unsurprising that when we asked people how well they thought their health system was working for obesity prevention and treatment, the results were again undesirable. Generally, stakeholders do not feel their health systems are working for obesity, and in high-income countries, less than half of the stakeholders felt it was working either well or partially well. Again, the situation is much worse in lower middle and low-income countries, where only 16% of stakeholders felt their country was doing well. Related to the financial protection component of UHC, we asked stakeholders how obesity treatment was generally funded in practice. What we found here is that for those that did answer the question, the majority of obesity treatment is paid for out of pocket. Unlike the UHC ideal, very little care seemed to be paid for by government provision or social insurance, leaving individuals financially at risk. Considering the rising rates of obesity globally, this demonstrates that UHC cannot be achieved unless we change the ways in which obesity care is funded. We also looked at the availability of suitably qualified professionals in both rural and urban areas, speaking to both the equity and access component of UHC, but also the quality component. And what we can see here is that on a scale of 0 to 10, neither high income or lower middle income countries had a mean of over 5 in either urban or rural areas. And so it is clear that there are not enough specialists across the board, regardless of the income level of the country. And finally, when we asked the stakeholders what were the main barriers to treatment, respondents reported a range of barriers relevant to UHC efforts. For example, inadequate training for professionals at number 1 and lack of specialist multidisciplinary teams at number 5 mean that quality, timely care cannot be provided. Additionally, financial constraints at number 3 mean individuals are less likely to be financially protected when care is provided, but also it is likely to impact the quality of care they receive. Considering all of the provisional findings, the clear take-home message is that obesity treatment is still very accessible for most people, whether it's for financial or structural reasons. This demonstrates how much more work needs to be done for obesity to be properly provided for within UHC and for the UHC aim to improve health to be attainable. Thank you.
And now it's our great pleasure to introduce Agbo Uridinachi, who is president of the Obesity Society of Nigeria. And Agbo will speak about obesity and UHC from the Nigerian perspective. Agbo?
Thank you so much for the opportunity. I'm going to talk about obesity in Nigeria. And next slide, please. And I'll go with the following outlines: the prioritizing obesity in UHC, UHC in Nigeria, the situation in Nigeria, and then barriers to obesity management, the challenges and the recommendations. Next slide. Thank you. This is just a diagram to show the different complications of obesity. We've seen that it's multisystemic, affects almost every organ, in fact, every organ. And it's really nice if we start speaking out loud on why obesity should be prioritized when it comes to management of chronic illnesses. Next slide, please. And then in Nigeria, we try to quantify the indicators in terms of percentages to show us our position and the pathway to achieving these indicators. So the total health expenditure should be at least 4 to 5% of gross domestic products. And the out-of-pocket spending should not exceed 30 to 40% of total health expenditure. And over 90% of the population should be covered by prepayments and risk pooling schemes. And close to 100% of the population should have access to social assistance and safety net programs. But these are the target indicators to monitor the progress. But then in reality, what are we really seeing? Please, next slide. Thank you. In reality, in Nigeria right now, the government health expenditure as a share of the gross domestic product is 0.59, and current health expenditure is 3.6%, while out-of-pocket expenditure is 72.3%, which means only about 7% is covered by prepayment schemes. And then we have only about 2% having access to social assistance and safety net programs. So we are really, really far from achieving our indicators, although we are on the path towards it. We are really happy that in 2014, the National Health Act was passed, but we're still dependent on it being implemented. And in Nigeria, only about 20% of the 30,000 public primary healthcare centers is just functional. Next slide. So we also tried to assess invariably obesity situations in Nigeria, and in a research we carried out on 141 type 2 diabetic patients being managed in a tertiary hospital in the southeastern part of Nigeria, we found out that 29.8% and 22% lived with obesity, overweight and obesity respectively. And 49.5% of these type 2 diabetic patients in the obese and overweight group have been receiving treatment for 5 years. There's really a need to introduce anti-obesity drugs in their management. And because we've seen the different complications that obesity can bring about, it is really pertinent that we face obesity, because prevention and control of obesity is the backbone of prevention of non-communicable diseases. Thank you. And in another research, we also tried to assess the barriers to obesity management. We made a score of 0 to 5. And in the results, we found out that lack of training, lack of time in the clinic setting for counseling, lack of structures to support patient referrals for obesity management, and lack of guidelines made a mean score of 4.0. And then lack of obesity clinics and weight management services had a mean score of 3.7, while lack of patient interest and lack of knowledge of anti-obesity drugs made mean scores of 3.5. Thank you. So we try to group these challenges using a systems approach. When we talk about the health system, looking at it in a systems way, we grouped them under the micro, the meso, and the macro. Just like a preamble, micro consists of the relationships in existence in the health system. So when we talk about micro, we are referring to patient-to-patient relationships, doctor-to-patient relationships, and then the activities that go on in this level. And then at the level of the meso system, we talk about the organizations, the communities involved. They are still part of the health system. And then the macro system are the policies, and then the big wigs that make the policies. And so we try to arrange these challenges according to the level of the health system in which it's operating. So in the micro system, we found out that limited research in the field of obesity, unavailable structured care for people living with obesity, out-of-pocket payments still at 70%, and lack of well-trained health professionals delivering care are all challenges that we are facing at the micro level. And then at the meso level, which is the organizational level, the community level, we found that cultures that fosters the growth or the increase in obesity is also affecting it. Lack of structured care, lack of medications, technologies, interventions that will help solve the problems of obesity, lack of training, curriculum to cover obesity prevention and management, inadequate infrastructure, and poor service quality. We're all operating at the meso level. And then at the macro level, lack of political will. Lack of commitment towards policies that will help reduce problems of obesity, and poor implementations of these policies. For example, food labeling. Nobody is talking about it. Poor advocacies when it comes to that. And we know that food labeling is a policy way of reducing obesity at the public level, and weak governance and enforcement. Next slide, please. So my recommendations, I'd really want to thank the World Obesity Federation for taking the lead and being a strong and very loud voice in setting the action plans to tackle the problems of obesity. And it's necessary that collaborations that can help healthcare professionals to deliver bariatric surgery services in Nigeria could be formed within member organizations. And then advocacy to prioritize obesity medicine should be lauded. And a viable and people grassroots-oriented primary healthcare center is still key in achieving universal health coverage. And there's need to implement fully the basic healthcare provision fund. Because this program, this fund, is being rolled out so that the primary health centers can actually thrive. These are my references. Thank you so much for listening.
Thank you so much. That was excellent, Agbo. And now we hear from one of your colleagues from Nigeria from the patient perspective. And this is, we're privileged to have Dr. Kingsley Chijioke with us today.
I'm very ready. Thank you very much for this opportunity to present once more. I'll be talking about obesity patient perspective. My name is Dr. Okeke Kingsley Chijioke. I'll be looking at the presentation on the following outline: my brief history, personal experiences, other experiences, obesity and Nigerian factor, access to healthcare services among the obese, the impact of scope school training on my experience. I'm the 5th child in a monogamous family setting with 11 children. My father was obese and my mother was not, but my father had a stroke in 2009 and died from it. Most of my siblings have normal weight except 3 of us. I was not obese growing up. My history started in 2005 after I fell ill. Following that sickness, I lost a lot of weight. And as a tradition in Nigeria, if anyone is sick, he is given any kind of food he requests to, as long as the person is recuperating from his illness. So in order to regain weight, I ate all manner of foods, which are mainly carbohydrate-based. To me, gaining weight and to other people was a sign that I have recovered, and it was a great achievement. Since then, till the last year, my weight kept increasing until it stabilized. I once had a BMI of 33.2 kilogram per meter square. My weight started dropping late last year, all thanks to World Obesity for the impact. Presently, my BMI is 29.7. My personal experiences ranges from stigmatization, low self-esteem, bullying, depression. In stigmatization, I was removed from the departmental team. We normally have a departmental team, we play football, but because of my weight and they felt that I was not fit enough, they removed me from the team, even against my wish. I had several low self-esteem. I looked down on myself, thinking that I cannot measure up. Friends bully me a lot. They call me all sorts of names. Even when I have won them severally, I've had to quarrel, I've had to fight because of bullying. And my weight got me depressed. At times I feel withdrawn, I don't like to talk with people. My mood is always down. I have this body shaming. I never appreciated my image. I hardly look at myself at the mirror. When I was on campus, I lost a girlfriend. She didn't tell me why she quit the relationship. But I got to know from her friends that she doesn't like my shape. I was traumatized psychologically because of my weight. I don't like people talking about weight. I never contemplated suicide attempt, but my sister had a very close attempt at taking her life because she was dropped from joining a trip just because they said it is better to carry 2 more persons than to carry 1 person because of her weight. So before they could come back, she had taken poison, but thank God she was rushed to the hospital by a good Samaritan who saw when she took it, and eventually she was recovered. She recovered from it. And that equally helped, her weight led her to wrong choice of partner because she didn't really believe in her image. So when one elderly man who is far older than her age approached her, she accepted the marriage proposal, even against our advice. And when we asked why, she said it's because of her weight, that she's getting older. Other people's experiences I have witnessed. A lady got drowned in my village due to stigmatization of her size. Another took poison and died when we were in the college. I have heard of several divorce cases, broken homes because women will be accused of not being able to control their weight. They were seen as glutton. And there's always a blame game on the obese, telling them that they are the one or they are the cause of the problem, that because they cannot hold their appetite. Whereas other people see it as a gift from God, they see it as a blessing, especially the younger girls. Some others flaunt their weight and proud themselves of their size. If you go, there's a meeting they normally called August meeting in my village or in Nigeria. It's a normal meeting that is held in August. You see women that have big size, they will just come to flaunt their size. Whereas others see lean people as being wicked, and that is why they are slim. They are slim. Our culture is one major reason obesity is thriving in Nigeria. Generally speaking, obesity is the societal impression of a good life. It is never considered a disease to be fat among most Nigerians, though this impression is gradually changing. A fat woman in Nigeria relishes her body weight and accepts it as a gift of nature. She considers this as an achievement and fulfillment of her heart desire. A man is considered very rich based on his size. There is a proverb in my people, they say, when you see a big man, you see his size. That a big man is seen by his size. There's a practice of omugwo and fattening room. The omugwo is a situation where a woman puts to bed. It is assumed that she has lost a lot of blood. So she will be prepared with all sorts of fattening foods. There will be a dedicated cook. She will not be doing anything. They will be feeding her, giving her all sorts of food to make her recover. Fattening room is a situation where a woman wants to get married. They will place her in a special room for 6 months or even beyond, basically to feed her of her choice foods, to make her look big. Even when I eventually got married, I was blamed for there was a day my mother called me and said, "Are you sure that I'm not maltreating my wife just because she was slim?" I said, "No, that's her nature." So people see a freshly married woman that she must add weight, she must be fat. If you are not fat, if you get married, that means that you are not being treated well. There's a popular saying that big is beautiful and slimness is stinginess. So being slim is associated with hardship, troubled life ravaged with illnesses, and all sorts of blame games. Whenever they see a slim person, they have a lot of interpretation to it. Who knows what he's suffering from? It's because he cannot eat. Look, that's why he's looking like that. And that's why even slim people want to get fat. They want to add weight. They will always tell you that, I don't like my shape. Another factor that contributes to obesity is our attitude towards physical activities, where people see walking or trekking as a means of hardship. If you want to exercise yourself and you want to trek, people say, doctor, why are you trekking today? It's like you don't have fuel in your car. What's happening? Is your car bad? And people equally see driving as a means of showing wealth. Big man is big. That is why people drive. And people equally see exercise as, if you see people exercising at the stadium, they will see them as jobless people. So these are factors that militate against people even engaging in physical activities. Another problem is our food preparation. We hardly eat liquid or semi-liquid food. We prepare our food strong, our soup thick. We have varieties of food, and majority of them are carbohydrate based. I showed some pictures of some of our foods. These are the swallow foods we eat. These are our soups. And you can equally see even the beans. So we prepare our food thick. Look at the meats we eat. This is how people show that they are big, by eating this kind of meat. If you go to where they sell some of this food, where these things are prepared, you see, anybody that is eating it is, this one is a big man. Anybody that is not drinking water is not a big man. But for this person to be eating this kind of food, he must be rich. And people go into doing those things even to showcase that they are rich. Access to healthcare among the obese. Next slide. Access to healthcare among the obese. Obesity is not seen as a disease yet in Nigeria. The obese don't go to hospital because of their weight. They go there when there is complication. And even when you go there, I've not seen anybody, there is no weight management clinic in Nigeria, in the Nigerian hospitals. So no specialized clinics for the obese. We've attended scope school. I've seen a lot of drugs. I've heard of a lot of drugs, but I've not seen those drugs in Nigerian market, except the one that we use to manage diabetes, metformin and Daonil. But all these Olisat, the rest of them, I don't see it in Nigeria. Few centers in Lagos and Abuja where you can get bariatric surgery, but that is at a very high cost. And most of the surgeries they do are not actually bariatric surgery. It's just liposuction. And cost of treatment are usually out of pocket because majority of Nigerians are not covered under National Health Insurance Scheme. Only less than 10% of the Nigerian population are covered by National Health Insurance Scheme. And even the services they offer are not optimal. So the common surgical practices has been liposuction and fat transfer. No trained manpower to handle obesity in Nigeria. Thank God for World Obesity Federation and what they are doing through scope schools. That's the only manpower training that we are receiving presently in the country as regards obesity management. Impacts of scope school or my experience. My exposure to scope school through World Obesity Federation has greatly impacted on me, both as a patient and as a public health physician. My knowledge base about obesity has tremendously improved. I've had psychological healing. There's a way I see myself apart from the way I used to see myself. My weight had dropped and my BMI reduced to 29.7 kg. My approach in the management of obesity is better. I can advise others with obesity with confidence, and I'm being more practical about it. Interactions among network of professionals and friends, which I built through scope schools, are very valuable. And so many other experiences. Thank you very much for your time.
Thank you very much, Agbo, and thank you so much, Kingsley, for an excellent presentation. And next time we'll make sure that we have your sound sorted so that you can have an opportunity. So we have an opportunity to hear your voice. Now we're going to hear a bit about obesity and universal health coverage at the World Obesity Federation and what we're doing.
Yes, thank you. And yeah, really sorry that we couldn't hear your story in your own words, KK, but sometimes this happens, and thank you for those on the line for bearing with us. We did a test run yesterday and it worked perfectly, and so we'll really hope to find a way to share that online anyway, so watch this space. So yeah, I'd just like to flag some of the resources that and some of the work that we have been doing here in London on universal health coverage that we would like our members to read more about and to participate in on social media. So we have there's just the screenshots from the web pages, so please do have a browse. We have a blog series that is coming at the moment, and the first one is there for you to read: Obesity, Universal Health Coverage and Sustainable Development, an introduction, and it'd be great to get some comments on that, so please do have a read. We also have a policy brief on obesity and universal health coverage there on the corner, preparations for the high-level meeting that Johanna has talked about, which will give you more information on that and some of the key messages that will be feeding in. We also have, most importantly, potentially, the social media side of things, and that is a screenshot of our Twitter feed, which has been covering a lot of these issues on universal health coverage recently. And what we have is these great infographics, which you may have seen throughout the presentation so far. And as I said, these are available online very shortly. So there will be a social media page coming very soon where all this will be downloadable and available for you to take and to adapt and to use in your networks too. So please do be in touch as well if you have any questions. My email should be circulated with the slides and with the notes, and we'd love to hear more from you what you're doing in your country. We also now have time for questions.
Ooh. Do you want to speak to that?
Nope. Okay, I'll continue. Yeah. So the longer term goals are to strengthen health systems to prevent and treat obesity. And that links to what Junaid was speaking about earlier, that really the situation right now is bad. We know from our research and from your own experiences, I'm sure will back this up, that obesity is not being adequately dealt with at country level by governments. And we need to advocate for more services, for more people to be covered with obesity prevention and treatment interventions. And underlying this is the goal to recognize obesity as a disease, which is something that we will all be unifying around, especially on World Obesity Day. We also need more health worker training, and this is where we're really proud of our SCOPE project that Agbo and Akeke also alluded to. Secondly, we need to make obesity an essential service. And what we mean by this is that it should be seen, tackling obesity should be seen as essential as vaccinating children, really, because this is going to be such a major issue in all countries, and we need to make sure that that governments are taking the action that is required. And in order to do this, we need more data. We need, as I said, we need better data from countries to influence ministries of health, but also ministries of finance. Thank you. And here's a summary slide. We have Adela from Uruguay, with some questions as well. So please go ahead, Adela, if you'd like to share your questions or comments.
You should just keep here. You just read it.
Or we'll just wait a second for.
We saw one question which was about obesity being declared as a disease, and there was another question about World Obesity Day, so I thought maybe I can take a chance to respond to those while Adela writes up her questions on the chat section. So first of all, for recognition of obesity as a disease, that's something that many professional societies and organizations around the world have already done, and even the World Health Organization in some of its documents has supported that. But ideally, the process would be to have a WHO resolution, which includes language about addressing obesity in general, both through prevention and treatment, but that would include the recognition of obesity as a disease. That would provide the kind of general formal recognition that would then cascade out into national plans and definitions. So that's something that we are working on with our colleagues in Geneva and around the world. And that is an exciting opportunity that we'll be in touch with you, about which we'll be in touch with you to discuss. The other is just a reminder on World Obesity Day that we are very excited that we are working with colleagues all around the world, including many on this call, as well as others such as the Obesity Action Coalition and the Obesity Canada, for example, to have a unified Obesity Day starting on March 4th. So this year, October 11th, we will still have, there will be World Obesity Day activities, launches of reports, a number of activities around the world, but we will have a brand new, even more powerful World Obesity Day coming on March 4th. So now I think there were a couple more. Was there another question from one of our colleagues? Okay. No. Okay, so then I think, but thanks for those questions. Those were excellent. And so, Rachel, did you want to finish off?
Yeah, so I've just got this final slide here, which is summarizing the presentations that we've seen. And really this idea of universal health coverage is a unifying goal for us working on obesity, but also for many other health communities, for other diseases, for the non-communicable disease community, the NCD world that we were involved with last year for the high-level meeting on NCDs. So it's really an umbrella, and you will have seen the umbrella, and you will see it on social media for sure in the next few weeks. It's an umbrella for everyone to come under. So rather than everyone advocating for their own issue, although that's also important, but also to ultimately be advocating for health for all. And actually together we're stronger, and especially when we're speaking with governments and speaking with policymakers, we need to be unified, and actually UHC is an opportunity to do that and to engage with other communities in our countries and in global health more generally. At the same time, at national level, in health systems, we can then focus our efforts on helping be clear, what do we want them to look like? What do we want obesity, how do we want obesity to be better included? And to have some really clear ideas for our governments and for our policymakers on how to make that happen. And that's, I mean, this is the longer term goal that on the previous slide, but this is something that we want to work on in the coming months and years. And that's, yeah, why we're looking to speak to our members more to understand the situations in different countries and what are some of these asks that we can make to governments and to the health policy makers, to mean that everyone can have access to obesity prevention and treatment services. I think that's. So the final words are actually from Johanna, from a piece that she wrote, which I really encourage you to read, which is in the a blog in the British Medical Journal. Do you want to say something on that? No, okay. The UHC, this is an opportunity. So I'll leave that. I'll leave those final words up, and I'll just we'll leave it. We're just seeing if there's any more questions online. Please, don't be shy. If you want to have any clarifications, you can also be in touch with any of the speakers directly, and we can facilitate that. No.
Okay. Thanks, everyone. That was excellent, and we really appreciated your comments and participation today. Thanks. Okay.
Thank you.
Thank you. Thank you.
Thank you.
Okay, we're going to exit out now. Thanks especially to our speakers. We really appreciated it.